pleased that we have Dr. Kanda here all the way from Gauteng. He's at Weskoppies Psychiatric Hospital, and I think he's actually sitting at Weskoppies this evening as he speaks to us. And he's going to be focusing this evening specifically on mood disorders, which is actually the most common mental disorder that we see in our rural healthcare settings, and quite often the one that there's the least information on. So Dr. Kanda was born in the Congo, where he completed his medical studies in 1989 and underwent a 4-year postgraduate training in Neuro-Psychiatry from 1990 to 1994. He's been working in psychiatry for more than 20 years, and whilst working here in South Africa, he's obtained a diploma in mental health from the College of Medicine, as well as clinical logotherapy associate and diplomate certificates from the University of South Africa and the Viktor Frankl Institute of Logotherapy. He's also got a master in Sociocultural Anthropology from the University of South Africa. He's been a member of RuDASA for many years, since 2009, and he's been very much involved in our rural mental health projects. He's currently working at Weskoppies Psychiatric Hospital as a senior clinical manager, and he's also a logotherapy facilitator at the Viktor Frankl Institute of South Africa and an e-tutor for the Department of Anthropology at UNISA. So his professional interests are centered on the interaction between medicine, anthropology, and psychology. In other words, interactions of health, culture, and mind with a meaning-centered existential approach. That sounds very cool. Very welcome, Kanda. I'm going to hand over to you. I'll stop sharing my screen and you can start your side.
Thank you very much, Madeline. And it's a real pleasure to be with you this evening. I believe you can see my screen.
All beautifully, thank you.
Okay, thank you. Yeah, so it's again a pleasure for me to join my colleague and discuss some issues around mental health, focusing on mood disorders at the district setting. The aim of this presentation is threefold. The one is to advocate mental health care at the district level. The second one is to improve the identification of mental disorder and their management at the district level. And the last one is actually to encourage each one of us to take care of ourselves in terms of self-care. I thought to make it a little bit more practical and real, that I should share some stories with you, which I put as a diary of a doctor at a clinic, at a district hospital. So it is 9:30 at night, and I'm called at casualty department of our hospital after a busy clinic during the day. I'm called to come and assess a 15-year-old girl who was brought for attempted suicide using an antidepressant and painkillers tablet. The staff at the casualty report that this is the known patient who has been treated at hospital for about 3 years, and she has been admitted several times for attempted suicide. The very same colleague, the staff, are very frustrated about with the patient, and they are not much engaged in taking care of this young lady. This is frustrating for me as well, and as I've been having a busy week. So actually my week started on Monday with a long ward round in a surgical ward where a disruptive male patient with manic features was admitted during the weekend for a fracture of the right arm. This patient sustained this fracture in a fall while he was drunk and roaming around in his neighborhood. The following day, on Tuesday, at our OPD, I discussed the management of a woman with a colleague who had come to ask if I could cover his maternal health OPD clinic this coming Thursday. This woman, who has a thick hospital file, has been treated for years at our OPD for high blood pressure. And recently she was diagnosed to have diabetes, and she came to report that her depressed mood has gotten worse and she's overweight. As I'm reflecting at casualty about this 15-year-old patient, I remember with frustration that after my night call, I have to cover my colleague on Thursday at the maternal health OPD clinic. And they've been reports that there are many mothers, new mothers, who present with ill-defined symptoms with depressed mood. And I'm also aware that on Friday, I have a round in our
Kanda, we've just lost your voice for the last minute or two. We can't hear you. I don't know if it's just your reception or if it's on my side. If it's on my side, can please somebody chip in if you can hear him. Kanda, I can't hear you yet. We'll just wait for your connectivity to... looks like we lost him. We'll just wait for him to come back on. I assume that was... you're back. There we go.
Yes.
Kanda, we can't see your slides. You'll just have to reshare your slides. And then I'll show you.
Let me.
Okay, good. So if you go back one slide, I'm going to show you where if you just go back.
Yes, I think I was here.
No, just go back one. We missed a little bit of it. I'm going to show you. Okay, there where it says the next slide, just go to the next slide. There where it says, and I'm aware that on Friday, I think you were roughly about there.
Yes, yes. I'm aware on Friday I have a ward round in a subacute ward where we have a number of patients who have chronic conditions and their families are unable to care for them at home. Some of these patients present depressive symptoms. So with these stories, I thought I wanted to say we do have mood disorders, and
Kanda, we've lost your sound again. Just let you know.
Mood.
Sorry, you're not back yet. You're still a little bit unclear. It's still going in and out.
Can you hear me now?
Yes, now I can hear you.
Let
You
me
just
try
have to
something
start again from the 1 in every 8 people. That's where we lost you.
Okay, so the WHO report that 1 in every 8 people in the world have mental disorder, and there's been a significant increase of number of people living with anxiety and depression since the COVID pandemic. And in 2019, it was reported about 40 million people suffered from bipolar disorder. So from these reports, we can also add from our own observation that the many disruption caused by COVID-19 pandemic is resulting into more poverty, violence, death, and various losses. And this is going to lead to more mental disorders. But then when it comes to mood disorders, as I said, they are part of mental disorders, and generally mood disorders are defined as clinical syndrome, which are mainly experienced as abnormal mood. And we do have a difference between mood and affect, the mood being a pervasive and sustained emotion, which describes one's feeling about oneself and the world, while affect is more relating to the emotional experiences which are observed as response to varying emotional states. So if we could continue still in terms of epidemiology, someone has written to say that psychiatric illness is associated with increased burden of somatic disease. I thought this is very important, and it is applicable to mood disorders as well. So locally here in South Africa, there's been a landmark research which stated that the three leading common mental disorders among adults were anxiety disorders, substance use disorders, and mood disorders. And lastly, recently, it was found in a research recently in 2022 that 25% of prevalence of people presented with probable depression. And of these 50%, it's also probable depression with anxiety, meaning that the two conditions have been happening together at the same time. So in terms of impact, one can say that mood disorders do have an impact at different levels, from the individual level, causing distress and impairment, which affects the educational, occupational, and social activities. It also impacts the family, which can result into failed marriages, poor parenting, and very importantly, one has to realize that it's through this kind of disorders as well, we do have what we call transgenerational transmission of trauma and stigma. But the impact is also felt at the community level with more poverty and violence, and as well as at workplace. When we talk of a workplace, it's important to also include hospital as a workplace. So mood disorders definitely present a burden for our healthcare system. And in terms of numbers as well, that since 2007, it was reported that depressive disorders is the third leading cause of years lived with disabilities, following low back pain and headache disorders. But it's important to note that bipolar disorder might be less common compared to the depressive disorder, but however, it causes more disruption in people's lives. But so very complex conditions, and there are many reasons why this is so. One of the reasons is that mood disorders quite often would happen together with other conditions, be it other mental disorders like anxiety disorders or substance use disorders or personality disorders, but also these can also happen together with other physical conditions as HIV and AIDS, high blood pressure, diabetes, and so on. So from the anthropological or social sciences, we would find people would use the concept of syndemic condition just to describe that these are conditions which happen together at the same time, affecting a quite number of population, and they are driven by a number of social determinants. And this is why some are even talking about not only of social determinant of health, but also social determinant of mental health. And these are, in our conditions, poverty, unemployment, violence, social injustice, and discrimination, and so on. So just to illustrate the complexity of mood disorders is to look at the cause of mood disorder. More and more, people talk more of risk factors, just to say that mood disorder result from an interaction of a number of factors. And these factors, many, as you can see on this slide, from physical factors to sociocultural factors and psychological factors, all of these interacting to result into mood disorders. So generally, there are different types of mood disorders, which are which can be broadly grouped into three categories. The first one are depressive disorders, where you have different type of depressive disorders, including here one which is observed among children, and I would hope to give more details, the disruptive mood dysregulation disorder. And you have the second group, which is made of bipolar disorder, with different type of bipolar disorder as bipolar 1, bipolar 2, and cyclothymic disorder. And lastly, you also have mood disorder related to a condition related to mood disorder, which are made of adjustment disorder with depressed mood or mixed bipolar episode. So these, as I said, the different categories. So I would like to present here just the two main group of manifestation. The first one being manic episode. With manic episode, it's very important to mention that the fundamental disturbance here is abnormal and persistent elevated mood or irritable mood. And generally this can be present in different degree in terms of severity from hypomanic episodes to manic episode with or without psychotic symptoms. So these fundamental disturbances which relate to the mood accompanied by other symptoms as grandiosity, reduced need for sleep, pressure.
Dr. Kanda, we've lost you again. We'll just give you a minute just for your, we lost you, we still can't hear you.
Can you hear me now?
Now you're back. You were at reduced need for sleep when we lost you. You can just take on from there.
Yeah, reduced need for sleep in manic episodes, distractibility, psychomotor agitation, like in the case of one of the patient I've presented initially. Depressive episodes, we also have fundamental disturbance at the mood level, which is characterized by pervasive, depressed mood and or anhedonia. Anhedonia, which is actually the lack of pleasure, that the user or the patient is unable to experience pleasure in activities he used to enjoy. And again, here you have this depressive episode which can be presented with different degree, from mild to severe depressive episode with or without symptoms. And they do come with other manifestations, somatic symptoms, like loss of appetite, loss of libido, loss of reduced energy, pain. And you also have cognitive manifestation were made of hopelessness, reduced self-esteem, a sense of worthlessness, guilt, and impaired attention and concentration. And you also have behavioral manifestation as well, which could be psychomotor retardation, agitation, or social withdrawal. So as I previously said, you also have a condition mostly described in children, as it's happened between the age, started between the age of 6 to 10, called disruptive mood dysregulation. And this is made mostly of recurrent severe temper outbursts with a frequency of 3 to 4 times a week. And in between these temper outbursts, there is irritability. So when it comes to women, we also have the premenstrual dysphoric disorder, which is made of, besides the somatic symptoms, it has depressive symptoms, which present during the last week before the onset of menses. And it's said to improve once after the menses. So you'd have here affective lability, irritability, and marked anxiety. So the mood disorders as well, like any other illnesses, they do have their cause and there are different causes, but generally mood disorders are recurring condition, meaning that they happen by episodes which repeats with time. But sometimes these episodes can be persistent. And generally, it is observed that the onset of these mood disorders is around early 20 years. But we do have cases where they start late age as well. So it is important also to note that people who present with the first episode of depressive disorder may develop bipolar disorder 1 or 2. So it is important then when we have such patients to monitor the possible progression to bipolar disorder. It is important to also make a difference between relapse from recurrence, the recurrence which is basically a new episode. So it is also important to mention that the cause of mood disorder is also shaped or dependent of the environmental influences. Mood disorder as well, like many other medical conditions, would also have differential diagnosis. These could be general medical conditions which could present with mood symptoms. We do have mood disorders which are secondary to substance use, and we also have other mental disorders which can present with mood disorders and have a picture or of a mood disorder. When it comes to children, and even in adults as well, children who present with attention deficit hyperactive disorder, they might also be mistaken for having a mood disorder. But it is important at this stage to mention that depressive disorders specifically are different from grief and burnout. I hope we'll have time to talk a little bit about that. So when it comes to having investigation with mood disorder, the investigation has to be understood that we have two type of investigation. The first group of investigation is to help exclude any physical condition. As we said, some of the medical conditions could be
Kanda, I've lost you again. You were talking about physical conditions. We'll just give you a second for it to clear, the air to clear, radio waves to come through. We can't hear you yet.
Can you hear me now?
Now you're back. Now you're back. You were talking about physical conditions and the importance of excluding those.
And my slides?
Yes, you're on the slide. I can see your slide.
Okay. Can you hear me?
Yes, we can hear you. You can go ahead. You were talking about now the slides are gone.
Yeah, I think it's my connection. I'm hoping I'm going to be reconnected soon.
Okay, no.
Yes. Sorry for that.
No problem. There we go. We can see your slide. No problem. You just have to unmute yourself. You're on mute.
Yes, was I here?
There we go. You are back and we can see your slide, and you were talking about excluding physical conditions.
Yes, so we need to exclude physical condition. That's one set of investigation. The other set of investigation is basically to establish a baseline, as the management is a long-term management, and the medication used can have side effects which we need to monitor. Sorry. Okay, so if we can come to back to our story with our Monday patient who presented with manic episode, examination and some medical investigation based on the presentation and the context to rule out mostly delirium, which is a medical emergency, but which can present with psychiatric manifestation. We would also have to perform a mental state examination to rule out other mental conditions as psychotic disorder, which could also have some mood features. So when it comes to the management of a manic episode, we have an acute management and long-term management. And generally, these two start together. The acute management is basically about containing the patient and trying to limit the disruption and distraction this patient can cause. And the long-term management would have to use one of these mood stabilizer and, if possible, and some of the antipsychotic now to control or maintain a stable mood for our patient. So it is important here, I wanted to say that in the ward, in that surgical ward, it's important as early as possible, as we are containing the patient, to have a recovery model which is based on resilience, meaning that this patient can recover and then make use of social worker, for example, who can start assessing the environment of the patient and see if a referral can be organized, a referral in a psychiatric hospital or in a rehabilitation center. Remember, we said it's the patient who has been using substances. So when it comes to depressive episodes, like on our Tuesday, a patient who came, it is important to note that depressive episode can present with somatic, psychotic, and anxiety symptoms. So because of that, we would still have to perform a physical examination and with medical investigation to exclude any possible medical condition which can explain this condition. And we would have to perform a mental state examination to exclude other mental disorders as a psychotic disorder or anxiety disorder. And the management of the episodes would be, it's very important for us to establish if it's a first episode, which can be treated with some of the antidepressant as presented here, fluoxetine and citalopram, or to also make sure that if the patient has had previous depressive episode, or even previous manic episode, because that would then lead one to come up with a diagnosis of a bipolar disorder, which would require a different management. But here again, it's important to note that we need to consider in the management how we can help the patients with lifestyle change, because that also can help in the management of a depressive episode. With this, we might have to involve physiotherapists, dietitian, or psychologists. As I said, these conditions, they do affect children as well. But when it comes to children with depression, their presentation might be different, and it's said that they present more of having boredom, impairment of growth, reduced motivation to play, poor academic performance, poor feeding, somatic complaint, anxiety, and anger, with promiscuity as well. It is important to note that bipolar disorder might happen in children, even if it's rare, and quite often it's associated with ADHD. And one of the features is the reduced sleep, which could be an indicator of a child bipolar disorder. So in children as well, it's important for us to perform some physical examination to exclude the physical condition, which can explain this the mood symptoms, and also to exclude developmental disorders. On the other side, it's also important to exclude any other behavioral problem, and ADHD, as I mentioned, conduct disorder, and as well including normal reaction to loss. I hope I'll come back on this point of normal reaction to loss. So when a child presents with depressive episodes or bipolar disorder, it is important, like with other patients, that they might also have suicidal ideas or suicidal attempt. It's important to always include that as part of our inquiry when we are taking the history and assessing the patient. So in general, medication should not be the first line treatment for mood disorders. It is more recommended that with such patients, it's better to refer them to psychologists, psychiatrists, or occupational therapists who treat such children for better treatment. And as I said, while avoiding as much as possible the use of medication. So as I mentioned, that this mood disorder can also present with suicide. So we do have a situation where the patient, like the one who came on Wednesday in our previous story, a clear attempted suicide with an overdose. It's important to, again, assess physically the patient to exclude any sign of poisoning, intoxication, loss of consciousness, any injuries, which would need management in a medical ward or a surgical ward. But sometimes we do have patients who come with suicidal thoughts. Either currently, they would present currently with suicidal thoughts or even plan of killing themselves, or patient who present while we are taking their history that they have history of attempted suicide. So in both cases, it's important to assess and manage if there is any mental disorders, including mood disorders, if there is any chronic pain condition which needs to be taken care of, because that can also lead to suicidal behavior. And if there is any medical condition, we need to assess that and manage. But sometimes we need also to explore if they've been just stressful or traumatic events. So in this case, there might not be a mood disorder or even a mental disorder, but the person might be having a stressful situation or traumatic event which leads them to have suicidal thought. So in this regard, there is a group of disorder. You remember I said the three categories of mood disorders, one of them being the adjustment disorder. And according to the International Classification of Diseases, they've come up with a number of conditions based on the duration of the symptoms. So you have brief depressive reaction, prolonged depressive reaction, mixed anxiety and depressive reaction, and lastly, adjustment disorder with predominant disturbance of other emotions, which could be anxiety, depression, anger, or tension. Here again, I would like to draw your attention that generally these conditions do require mostly psychosocial intervention than medication. And again, to improve the lifestyle, like sleep pattern, diet, physical and cognitive activity should be part of day management. So when it comes to women as well, I thought I should mention some few points here. As I said previously, that they do have the premenstrual dysphoric syndrome, which is unique to women. But it's important to note that miscarriage and termination of pregnancy are risks for depressive disorder. So our patients who have miscarriage or termination of pregnancy needs to be screened for this mood disorder, and which need to be managed as soon as possible. And it's also important to note that pregnancy on its own present a prevalence of the prevalence of depression is high among pregnant women. And it's also important to say that mood disorders of pregnant or breastfeeding women are risk factors for neurodevelopmental and mental disorders for children. So if we do care for the wellness of children, it is critical for us to take care of the mental health of breastfeeding and pregnant women. And there is, of course, a group of disorders called behavioral disorders, which are also some type of mood disorders from the severe postnatal blue, which can develop into depression to postnatal depression. I've mentioned here menopause, which is not a mood disorder, but might present some symptoms which can be mistaken for a mood disorder, and it needs to be managed accordingly. Still, when it comes to women at the district level, when it comes to their management, ideally it should be recommended that one consults the maternal health and mental health specialist to work together. Either they should see this patient or advise according to our observation and reports. So in general, for pregnant and breastfeeding women, the recommendation would be to avoid as much as possible medication, as these might have an impact on the fetus or the baby who are being breastfed. But when it comes to medication, generally for depressive disorders, citalopram is the most recommended medication. For bipolar disorder, in general, all the mood stabilizers, it's advised to avoid them because of their impact on the fetus. But if one needs to prescribe medication, especially in acute cases of manic episode, for example, would also recommend that one seek the advice from a mental health specialist. And sometimes alloperidol can be used at a lower dose to contain the condition. However, for those who are already on medication, women who are breastfeeding and pregnant who are on medication and they are stable, it's not advisable to change their medication without consulting the mental health and maternal health specialist for guidance and further management. So as part of psychosocial interventions, one can provide psychoeducation, stress management, social support, and other intervention. All of these colleagues, they do have an impact in terms of managing mood disorder. And lastly, like in the case of the week, during on Friday, there's a doctor is reminded that he was going to go in the subacute ward where we have mostly elderly who are physically ill or other people who have got chronic condition. It is important to say with elderly, they can also present depression, which can present as a pseudo-dementia or a pseudo-neurocognitive disorder, because as you remember that some of the symptoms of depression are cognitive symptoms, which is poor attention and concentration. These can be so severe that the person might present as having dementia. And it's possible that sometimes one might have dementia with depression as well as comorbidity. So in general, when it comes to chronic physical condition, more and more it is established that there is a kind of bi-directional relation between physical conditions such as HIV, cardiovascular condition, and diabetes with mental disorders, specifically mood disorders, in this case, depressive disorders. So it is important in all patient with chronic condition to always screen for mental disorder and specifically depressive disorder. When it comes to pharmacological intervention, we would also advise to consult the mental health specialist while the patient is managed in a medical setting with a close physical monitoring, because there is a risk of interaction between the psychiatric medication used and the medical medication, and even with the medical condition. So it is important to be aware of that. And lastly, I would like to say, when it comes to this point, that it's important that we work toward an integration of mental health care with psychosocial intervention in palliative care. So I'm actually happy that I saw that one of the next presentation would be on palliative care. So as I mentioned previously, I thought I should also share here some thoughts about grief, which I said is not, it is different from depression and should not be considered as a mental disorder, because it is different from depression in a sense that, yes, there is a loss of interest or loss of pleasure, but this is limited to the diseased person. And if there are any preoccupation and guilt feeling, these are also related only to the, and generally the person going through grief would have longing and yearning of the diseased person. And they might have also intrusive images of the deceased, their loved one. And generally, when it comes to management, one has to avoid as much as possible medication and provide psychosocial intervention. So this is the same as well with burnout. Remember, with our colleague in the story I shared with you, it experienced a sense of frustration. Even the colleague at Casualty who received this young girl, they have a sense of experience of frustration. That's, I'm not saying is necessarily a burnout, but it could lead to burnout, which is generally made of these three categories of manifestation: high emotional exhaustion, high depersonalization, and low personal accomplishment. This is different from depression, and its management should be different. This is why this leads me to my last point I wanted to raise, is just to encourage each other that we take care of ourselves. Like any other human being, we can suffer from grief, from bipolar, from the burnout, and from any other form of mental disorder. So it's very important for us to be aware of our emotions, and as part of prevention and even treatment to help get better, to be part of a network and keep social and professional connection, and to be part of a transdisciplinary team. As you have seen, I've mentioned quite a number of times how we should involve other health professionals. So we need definitely to work as a team, and we need ideally to establish our team long before we have a crisis. So I would say let's stay connected and keeping moving. So I'd like to end my presentation by presenting these two main references. I've used different references, but I thought these were my main references I wanted to share with you. And lastly, I'd like also to acknowledge Madeleine, who I've been working with for so many years and kindly invited me to share some of my thoughts on this important topic. And I would also like to say thanks to two psychiatrists who graciously have agreed to make comment on my presentation to improve it. And this is Professor Leslie and Professor Kruger. So thank you.
Thank you very much, Meba. That gave such a lovely bird's eye view of such a large topic. And I'm also happy to see there's some interactions on the chat there as well. As a matter of fact, Kate, can I put you on the spot, Kate Cherry, to just talk a little bit about the role of the occupational therapist? Because I think one of the challenges we have in rural settings is that you don't often have a psychologist. I mean, you don't often have rehab, but you're more likely to have an occupational therapist around than having a psychologist. And they actually have I don't think we always realize how much of a role they can play. So Kate, if you want to perhaps just chip in for 2 seconds, and then I'm going to ask people if they do have questions, you're welcome to put your hand up or just put something in the chat, and I'll get to you in a moment. Kerry.
Kate. Hi, Madeline. Thank you. Can you hear me all right?
Beautifully. Thank you.
Okay. Well, thanks for giving me a platform for my usual plug for rehab. Yeah, I just wanted to chip in. So far, undergraduate education doesn't teach each other that much about ourselves. OTs don't only work with children, and we do a lot of mental health and psychiatry work in our training. And in terms of the Mental Health Care Act, we are classified as specialist mental health care providers. And we're the most likely in that category to actually be present in a district hospital. So if you have access to OT, refer your psych patients there. We have, so all the stuff that Meba was talking about in terms of lifestyle management, psychoeducation, coming to terms with the diagnosis, understanding what that means, working with the family, lots of stuff around medication. There usually is quite an adjustment process with that, dealing with potential side effects. We have that training, we have that background, and we probably have a lot more time than you guys do to go through all of that. Remembering also that working with someone with mental health concerns, you can get so much more out of them when you've known them for a while and you've got that relationship. And again, the kind of diary that Meba spoke about, you guys just don't have the time or the space to do that, whereas that is something we can do. So what I've done in teams where I've worked at a district level is generally the doctor manages the medication to a large degree and does the exclusion of the medical conditions. But then we work together in terms of monitoring how they respond to the medication, dealing with the kind of ongoing life stuff and trying to work towards recovery and prevent relapse. So yeah, remember that you have that resource if you do have an OT present.
Thank you very much, Kate. And I think also mood disorders in your rural setting is very much intertwined with work and life. I mean, it's an all setting,
very much so.
Much more acute in an area where there's not resources. And so tying all of that together is very important. Also want to mention that CMH, for example, where I work, which is a large regional hospital, our occupational therapist actually runs a substance abuse program, which I only discovered recently. And I was very pleased to, because normally that's one of the big issues is for our substance abuse patients as well, that the government has certainly not set up services. And it's such a huge issue in terms of healthcare provision for a lot of our patients. So also to encourage, I think occupational therapists sometimes don't have programs like that because we as doctors also don't encourage and use them. So it's also to be able to meet with your teams and say, listen, can we set up a substance abuse group? Can we set up some support groups even for some of these mood disorders and get these teams to actually start running things out in our rural areas? So that's a very exciting little contribution there. Thank you. I just want to see if there's no hands that I can see at the moment, no specific comments in the chat. This is such a big field that we can't possibly cover everything tonight. And so I would encourage you, we will be putting on the learning portal in the next couple of days, and those on your onboarding will get the packs, but it's all also going on the RuDASA learning portal, which you all will have access to as RuDASA members. And on that learning portal, we're going to be putting specifically tools that you can use around screening. So there's some very good tools, especially your PHQ 2, 4, and 9. For those that don't know about it, go and look up. There's some very nice, easy tools that a patient themselves can fill in as well to screen for depression or get some idea. You don't need a DSM-5 to necessarily be able to help you make the diagnosis. And there's some great calculators, you know, your MD Calc. I'll put it in the chat here as well. So MD Calc is one of those apps you download that's got every kind of, what do you call, calculator that you need, BMI or GFR or whatever, but they've got great mental health calculators, and even like a tool that you can hand over to your patient, and your patient can fill in preparation of a consultation that then gives you a score, which can give you some indication. And especially good, as Meba was saying as well, to have a baseline understanding of where your patient is at before you start treatment. This is also a good way then to monitor how they are responding to treatment over time. So I would encourage you to look at that as well. I've just noted there is a comment from Angela. If there's any hope for additional antidepressants to become available at district level. Angela, maybe just confirm for us, do you also just have fluoxetine and citalopram, and what other antidepressants were you dreaming about? Put her on the spot.
Is that
It's Angela Hartwig, maybe. Another one of the old RuDASA clan.
Thanks very much. Yes, we do have fluoxetine and citalopram, and we often have patients who don't respond to these. And then we have to get them referred to see the psychiatrist. Usually they get changed to sertraline, which is another option, but it's just somewhat of a limitation not to be able to prescribe anything else at a district level for those patients.
Maybe, I don't know if you know, in terms of the possibility of some of those being moved to secondary and primary EMLs.
I know that there is a discussion currently going on. It's a submission made, so I don't know the outcome. So hopefully we might have more, some few antidepressant added to the list.
Yeah, because I must say our options are very sparse at the moment, and especially if somebody can't tolerate a particular one, then that does limit one's options. I also don't know if I don't know if you have any thoughts. I was looking up, because we're busy putting the resource back together, in terms of trying to do a risk assessment on suicide, which is always very tricky. So you have that patient that's coming that you've mentioned as well, and you have to decide exactly, am I going to admit this patient? Can I send this patient home safely? And I would love your comments on the sad person score, or the modified sad person score. When you read different things, some people say it's got some use, and then one article was saying completely useless, don't do them, use your clinical judgment. I don't know if you've got any feeling in terms of using the modified sad person score to help assess suicide risk.
Say that it's a good thing to use the SAD scale, but it's important first to establish first a rapport and have a proper assessment done first. Then the screening can be done. We cannot rely only on the screening because it can be misleading. I don't know if that makes sense. So the two have.
Kanda, we've just lost you for a second there. But yeah, yes, I agree with Kanda. I think one of the challenges we have with the mental health tools specifically, and that includes both your screening tools, your PHQs, all of them, is they're not quite the same as doing your GCS, which is just a purely objective score that what happens within the interaction, how you ask the questions, how safe you make the patient feel in terms of being able to answer those questions, and also the cultural translation of these tools. So a lot of these tools have been created quite often not in South Africa, and when you can't literally just translate the sentence, for example, for your Xhosa or Zulu patient, because actually the information you need, you might have to phrase the question differently if you're going to use a different language. And I think that's one of the challenges with these tools, is that they've not necessarily been adapted always for our settings. I am desperately trying to find somebody in my hospital to translate them for us into not just literal Xhosa, but actually that it captures what we're actually trying to understand through these tools. I'm just checking if there's any last questions. I don't see any hands up at the moment. No last questions in the chat. Meba, do you have any last things you'd like to add before we close for the evening?
No, lastly, just like to say thanks again for the opportunity, and it was a pleasure to see Kate and other colleagues. And again, two things: let's integrate mental health while we are working with other health professionals. And lastly, let's take care of ourselves. Thank you.
Thank you very much. Yes, very important. And then in your pack that we did last week, the soft skills pack that my attachment did not go through, which we now have sent. Please look, there is actually a specific help number that's been set up in South Africa during the COVID times for healthcare worker support. So if you are struggling or you are not managing and you don't have somebody to talk to, please make use of that. There's a number and a website that you can go and look into. And there are some webinars on thriving in rural health in that soft skills pack as well. So please look out for that. And then, yes, we are completing rural onboarding. This is our last week. Your last packs will go out tomorrow, and we will have our last webinar next week, Monday night. It's a bonus one with ethics points. We always need to sneak in the odd ethics points. And this is going to focus purely within palliative care on the actual end of life decision. You know, when you have to put together those DNR or not put together those DNR, which is what happens more often, forms, those do not resuscitate forms, and unpick a little bit that conversation and what we need to keep in mind when we're having end of life conversations with our patients. So we'll be doing that on Monday night. Thank you very much, everybody. Have a lovely evening, and we hope to see you on Monday evening, or at least you will be able to pick all of these up on YouTube. Good night, everybody, and thank you again very much, Dr. Kanda.
Thank you. Thank you.